I wanted to take a moment to talk about our sponsor, Alt21, the foreign exchange and hedging platform that saves you time and money on cross-border transactions. A previous guest, Dan Gardner, spoke about forecasting and risk. One of his central points was, as he put it, the things we're doing now are so incredibly complex, to see even a little bit into the future takes an enormous amount of struggle, and even then we're going to make mistakes. As CEO of Newroll, predicting just 12 months out is hard. As we expand, variables and risks multiply. Anything I can do to take risk off the table is helpful. In the past, I've been blind to the risk of FX exposure in our budgeting. A small movement could eat into our investment budget and compromise our credibility when our forecasts are wrong. If you want to remove risk from your foreign exchanges without breaking the bank, head to alt21.com. That's alt21.com to find out more. I just wanted to jump in before this podcast starts to let you know that we recorded this episode with Richard Meddings before the news broke that NHS England would be scrapped by the UK government. Having listened back to the conversation, I think the discussion is actually enhanced by the knowledge we now have about NHS England's abolition. Firstly, the governance structure in the NHS remains broadly the same, other than NHS England. So I think Richard's insights there are hugely helpful. But I also thought on reflection, it was interesting to note the disconnect in the narrative between the way Richard presented the board's activities, which struck me as being high performing in a difficult situation, and the perspective of the different stakeholders. The NHS Trust CEO, who is infamously quoted as calling the NHS England as the biggest kick-up, kick-down organisation in public life, but also clearly the government perspective, which led to them disbanding NHS England. It also serves as an example of what we talked about in the discussion of the challenge that those boards exposed to government faced when you get new government ministers or new governments coming in who are looking to impose their vision on the organisation, which might be for very good reasons, but can make it very difficult for an organisation who's trying to navigate that constant change. Let's hope that these changes are good ones that will allow the organisation to set on a good, stable course from here on in. With all that said, I hope you enjoy the podcast. Hello and welcome to Enter the Boardroom with Newroll. I'm your host, Oliver Cummings, CEO of Newroll, the board search specialist and market leader bringing science to the art of board hiring. Today's guest, Richard Meddings, is Chair of NHS England. Formerly, he was Chair of TSB Bank and Hastings Opportunity Area, a government social mobility initiative, trustee at Teach First, board member at HM Treasury, and NED at Deutsche Bank, Jardine Lloyd Thompson Group plc, Legal and General, and 3i Group plc. Richard, a huge welcome and thank you so much for joining us today.
Hi, Oliver. It's a pleasure.
Richard, I'd love to talk about the NHS Trust board world. And perhaps for those who aren't familiar with that world, could you just start by mapping out the landscape in such a way that an interested commercial exec listening to this who doesn't have much knowledge can get a good sense of what it is?
Absolutely. I talk really for NHS England, just to be clear about that. So it's the NHS in England as opposed to across the UK. But if I map out the landscape for you, clearly it's a huge ecosystem. And at the top of that ecosystem, there is the board of NHS England. But there are also a whole range of other arm's length bodies who are overseeing different parts of the health system. But the main arm's length body, independent arm's length body, is the board of NHS England. Now, what that then oversees in terms of the ecosystem is, I'll give you some sort of stats. There are 230 trusts and they manage 550 hospitals. But what you look at is the trust board. So you've got 230 trust boards and they will cover what people watching this podcast will understand as hospitals. But actually there are acute hospitals, there could be tertiary hospitals, they can be mental health trusts, they can be community trusts. So there's a range of health interventions, and they are overseen by a number of organisations, most of which have independent boards with all the same fiduciary responsibilities that people watching this podcast would expect to have. There's also a set of geographical organisations. So as of 3 years ago, we introduced what were called integrated care boards, so ICBs, and they have boards which are populated with independent commercial and non-executives, as well as representatives from the health system, from local authorities, which is a really important partner, and from the voluntary sector, also a really important partner. And their role actually is to help to make sure that the priorities we choose to pursue are as relevant as possible to the local community that they serve. So that England is broken up into 42 different geographies, each of which have independent boards. So you step back from that, Oliver, and there's a significant array of boards which have very real responsibilities in overseeing particular points of the ecosystem that is the NHS.
So if someone thinking about getting involved in a board in the health service, how would you advise them to think about which part of that system might be most interesting? Do different parts of it offer different opportunities for board members?
Yeah, opportunities, different experiences. They have different objectives, although all focused around the patient or looking after the citizens. So if you stayed with a trust board, and we tend to call them hospitals, they're the providers in the system. Then if you looked at those, these are very big machines, actually. And just step back and think for a moment about what a hospital does and how many people it employs and the range of its services. It's quite often, probably because of television, we think it's all about the operating theatre. But actually, if you think about what those hospitals do, yes, there's operating theatres providing surgery, but actually most of it is people in those hospitals, in beds receiving care. And then coming away from that, they have emergency departments or A&E departments, which has lots of flow. Most people do not actually get admitted into hospital, but actually are treated. And then there's just a range of all the different, we call them pathways, medical interventions. So you'll have cardiac, cancer, musculoskeletal, the whole range of different health conditions that get managed. And each of those have different clinical teams. You have to deliver the service and you have to keep the patient right at the heart of what you do. And you have a huge workforce to manage, whether it's the doctors and the nurses or the admin staff or the back office staff or the porters, all of that has to be managed. So they are huge operations and they can employ thousands of people and they have budgets of anything from 500 million up to towards 2 billion. So they're very big machines. And I think they offer great reward, but they also require real diligence and real attention. And they're not easy machines, essentially, to oversee.
But if I think about the difference of the nature of role of sitting on the board of an individual hospital versus a trust versus an integrated care board, is it comparable to say the difference between sitting on a school versus a multi-academy trust? Is that the way to think about it? Trusts and the integrated care boards are just more complex, larger versions of what's happening in an individual hospital?
No, so I'm talking about providers. So there's 230 trusts, etc., are mainly overseeing hospitals, and they might have 2 or 3 hospitals within their trust. So actually, you can sit on that trust board. The ICBs I was talking about, they are different. They're a really good. I think they're a really good structure because they do bring that partnership into play on the board. And so when I referenced earlier, they'll have representatives of the voluntary sector locally, certainly the local authorities. Think for a moment about one of the challenges for the health service, which is we've created this ecosystem, but it has boundaries around it. And one of the most obvious boundaries is social care. And so people watching will understand the challenges that are faced crossing that boundary. So we have a challenge in the health service of about 13 to 14% of our beds are occupied all the time by people who are fit to be discharged, but actually it's hard to get them out, partly because actually is there a care home or nursing home into which they can go. That social care provision is provided separately. It doesn't come to health. It comes through the local authorities. So the local authorities are essentially the buyers of bed capacity for adult social care need. And so that boundary is really important. Then also, if you think about local authorities, much of what they can do in education, actually in housing. The reason I go there is it's estimated that about 20% of health conditions are what you and I might think are the body going wrong or the mind going wrong in some way. But 80% of health conditions are caused by some non-health, non-body factors. So it's caused by education, by poor housing, by air quality, by ultra-processed foods, by social media interaction. So most of the causes of ill health that hospitals end up dealing with, or primary care deals with all the time, primary care being predominantly the GPs, the pharmacists and so on, that they deal with all the time. But then you come back to the ICB board, and the ICB is simply trying to, there are 42 of them, and they range from populations of 500,000-ish to 2.5 million, so different sizes. They can be largely rural. Some can be just made urban centres. So they're very different in the communities that they serve. And actually what they attempt to do is to bring health into partnership with the other relevant players in that community to help to devise and allocate resources to those interventions which will make the most difference to the provision of healthcare. So they're really interesting. But there are 42 of those, and there are 230 boards, and they have different demands upon you. And they also are driven by what experience do those boards want to bring into themselves that are most relevant for the tasks that they face.
So can you bring to life for me maybe some typical examples of what a board member sitting on an ICB might face as a challenge, and what a board member sitting on a trust might face as a challenge?
We just sent out what are called planning guidelines or guidance for the 25-26 year for the whole health system. So NHS England has sent that out. And what's going to happen is those planning guidance, including budgets, essentially are allocated out into all the major nodal points, so be it the trust boards or the ICBs. Now, the ICBs have a role which is largely a commissioning role. So they have within them, they may have 2 or 3 different providers, different trust boards within them, but they also are engaged with primary care. So they're engaged with GPs, they're engaged with other providers of health services, but also volunteering services, citizen services, etc. They will have to decide with their allocated budget, but noting that within that budget, there's a further allocation into the providers, into the trusts. What services are they going to buy? So where are they going to allocate those resources in terms of how much of a particular health provision do I actually offer? Now, of course, actually, we then turn it round. The trust boards, they haven't just started today. They've been working for, in case many years. They have a momentum of shape, activity, resource, skill set. Some might be a particular cancer specialist hospital. So actually, they've already got momentum to which they're going to be given, allocated the resources to continue that practice. So actually, when you get those financial allocations, the ICB is, if you like, bridging across into the local authority. It's choosing what it wants to buy or commission from the providers, but it's a very cooperative relationship. It's collaborative, which is a really important structure within the health service. It's that behaviours are collaborative, not competitive. And it's looking to work with the providers about what are the services it provides to the local population. And in doing so, it's very reflective of what is that particular hospital's capability. Now, it might be a district general hospital, a DGH, which I'm going to call a very general service. Or it might be a hospital, Great Ormond Street Hospital, which clearly has a much higher proportion that attaches to children and young people. So you've got to reflect what are the services that are offered by your partner providers within your ecosystem. And then in primary care, is how much do you allocate in primary care to dentistry, to spend what we call specialized commissioning, not rare, but less frequent interventions. So specialized commissioning, how much of that budget do you hold for that? And for what? How much do you allocate for vaccination programs? So you've got to decide on the range of what you do and what you oversee, what you're essentially going to commission. Then you manage relationships, which asks for those partners to come forward and say, well, how do we help in engaging in, say, the social care boundaries? So what are we going to do, particularly in winter, which is when we get most pressure on the system? what's my bed capacity that I think I need to be buying as the local authority? So actually the hospital flow, as people get admitted to hospital, stay in hospital, get treated in hospital, and then come out, have I got the right bed capacity? So you can tell from my answer that it's a very complex ecosystem, and you're not singular islands. You're partnering all the time with different providers of different services, and you're doing that very much driven by the momentum of the machine that you inherit, because they're not new starts. And then we could go and we could talk about workforce, or we could talk about technology, you could talk about the estate. So what's the physical infrastructure you have to manage through? How much capital budget do you need to maintain it, or to develop it, or to build new? So there's an array of, really quite complex demands, whether you're sitting in an ICB or in a trust. I mean, they are brilliant. I do think they are, either of them actually are brilliantly demanding boards to sit on.
In a commercial board, which is my background as an investor, we would often start with a sort of zero-based budgeting approach each year, cutting everything back and looking at return on capital allocated to the different areas. I guess that doesn't work quite so simply in the environment that you're operating in. So what's the decision-making framework that a board member uses to determine, you give the example of how much to allocate to GPs?
A lot of people perhaps don't understand that the primary care world, the GP world, is in England, it's about 6,400 GP practices, and they're all they're mainly small independent businesses looking after 8,000, 10,000, 15,000 patients, but they are SMEs, they're small independent businesses with whom the relationship with the NHS is contractual, and it's an annual contract negotiation. So actually our relationship with GPs is a contract, and within that contract there's a sort of a capitation fee, driven by a formula, a Carhill formula, which attempts to adjust for different profiles of population, particularly attaching to levels of deprivation. So you adjust that capitation fee for the shape of the population that the primary care practice, the GP practice, serves. And then GPs are paid so much for you might pay them for how many blood pressure tests they do or how many vaccinations that they do, and they get paid. So there's a contract negotiation that happens with the GPs. And that happens every year. Now, it doesn't obviously get torn up every year. It's adjusted each year. More material things or different factors that have occurred come into the discussion with the Department of Health and NHS England and the GPs about what changes would we make essentially to the contract for this year.
So does that mean effectively the demand is determined by the population and your responsibility as a board member is to negotiate the pricing, or do you also have control over the supply? And can you turn around and say, actually, we know there's demand for X number of heads, but we're only going to give you half that because we need to allocate that budget into other areas?
So there is that does go on, which is where do you choose to allocate budget? But at the same time, there's always, can we be more productive? Can we be more efficient? And can we find those, if we're talking about financial resourcing, can we find those savings? But it's not just financial resourcing, it's workforce shape. So if you think about, say, nursing, so you have community nurses, practice nurses, district nurses, intensive care nurses, mental health nurses. So what's my workforce shape? How does it meet the demand I face? In a way, I'm pleased, Oliver, you asked about demand. I think it's little understood in general. And certainly when I have conversations with people outside the health system, is just the pace of demand growth that the NHS is seeing. So if I told you that this last year, the NHS did just shy of 380 million appointments with GPs in primary care practices. So that's the equivalent to more than 1 in 7 of the population has an appointment in primary care every single week. Now, in 2019, just before that, so in the year before COVID, that number was about 320 million. In the last 4 years, actually what you've seen is a 60 million increase, so an over 20% increase in the number of appointments that GPs today are providing. And they are such an essential part of the NHS, and they hold and manage a huge amount of health risks for the NHS. But they are providing very significant levels of support. The demand is going up. If we look at children and young people, particularly in mental health, In some mental health conditions with children, we've seen a 40% increase in the last year in the number of people presenting with those conditions. So actually what we're seeing is very high levels in demand. There was a report recently by a man called Lord Darcy, who used to be on the board of NHS England until about 3 years ago. Very eminent, very knowledgeable. But one of the things he put in his narrative, which was very helpful, was actually that society is sicker, that we are seeing a society which is bigger. So the population of England's grown 15% in the last 20 years or so, but it's also older and it's sicker. And part of that health condition comes from things like obesity, poor foods, goes to diabetes too, it triggers 13 cancers and so on. The national assumption is that demand for health services goes up at about 3%, just over 3% a year, would be a sort of working model across the range of the human condition. And actually, if you think about what that means, now imagine you roll that forward continuously over the next 10 years, that 3% compounds to 40%. So unless we find different interventions, unless we do better, unless we invest better, that 40% increase in demand in 10 years' time, are we really going to be able to handle another 160, 150 million appointments in primary care? There are only 38,000 GPs in England. So we're going to have to manage very differently and think very differently about the pressure on health and therefore the system that manages health from that continuous lift in demand, which is why we want, and the government wants, to do much better in prevention and try and prevent ill health. But that goes back to my earlier point. Only about 20% of health conditions we manage emerge narrowly because of health going wrong. Much of health outcomes are driven by poor housing, air quality, obesity, poor foods, and so on. So that's where you have to engage.
As a really clear articulation of the challenges board members are facing on NHS Trust, can you give me a sense of where you've seen NHS boards and board members add most value?
I'll do it from the NHS England board. I gave you 2 or 3 quick examples. So one of the things when I came into this role 3 years ago, we had been asked to do was to merge the top entities of the NHS. So there's something called NHS Digital, which runs all the main systems of the NHS. And if I told you that last year we transferred 44,000 systems onto the cloud, it gives you a sense of the scale and volume of that business. And that had a separate board. But we also merged with and absorbed into NHS England something called Health Education England, a separate board with separate responsibilities. And that runs all education and training of health professionals across England, engaged with medical colleges, universities, etc., nursing colleges. And so we absorbed those. Now, that meant 24,000 people came together in these entities and came into the NHS England ambit. And we had to run the NHS England board whilst making sure that those entities merged together, different practices came together. And importantly, we also took over 9,000 of the headcount out. So we merged them and we reduced the headcount from 24,000 to just over 15,000. And today it's down further. It's down at about 13,500. So we reduced the bureaucracy. We shifted 500 million of cost into frontline by reducing the head office bureaucracy and at the same time merged those different boards and maintained oversight over their obligations. What were they responsible for? And we've maintained that responsibility. Now, there was a colleague called Wold Collada, who is one of my deputy chairs, and he chaired the oversight group that managed that process. He brought a number of us, sat with him on that oversight subcommittee, and it existed for about 2.5 years and oversaw that process. Now, he devoted his external commercial experience and his rigor of that experience to make sure that happened. 2 quick other examples. Jeremy Townsend, who you'll know is on the board, M&S Finance Director. He chairs something called the CFO Advisory Group. Managing the NHS financials, the money, is a really testing job, and particularly in the last few years where we've seen periods of steepling inflation coming through. So think about those costs. And we've seen industrial action and wage settlements, pay settlements. So Jeremy chairs a group, again, with other non-executives, but sitting with Julian Kelly, the very good finance director of the NHS. And it's one of those groups that just helps Julian think through, how do I balance how do I manage the financial pressures on the NHS? Because one of the things the NHS is obliged by law to do is produce a balanced budget. We are not allowed to be in deficit. So by law, we have to produce a balanced budget. And that therefore requires very thoughtful management. And then there's another non-executive man called Sir Andrew Morris. He's one of those directors who's run very big parts of the system. So what does he do? He chairs what we call board to boards. So where we have a hospital trust in some trouble, either its operational performance is poor, its financial performance is poor, we grade them and we have board to boards support. So actually Andrew would sit with a group of the non-execs and talk with and meet with and go through the remediation plans of that board. And he probably chairs 80% of those board meetings, as well as those board to board conversations. So you sit as a non-executive on NHS England board, and below it, you've got these activities going on where members of the board play not just a board role at the main board meetings, but they sit and they lead and they guide and they architect how we engage with the system.
One of the hardest things I found as an independent non-executive compared to my time as an investor director is the lack of a network to support and challenge my thinking in the boardroom. I hope that Enter the Boardroom goes some way to filling that gap. But if you want a more structured, personal space in which to share boardroom challenges and opportunities, I'd recommend our new 12-month NED Mastermind program. Over 6 sessions, you'll meet with a highly accomplished group of 6 to 8 board directors to brainstorm and benchmark boardroom approaches. In each 2-hour session, one member of the group will share their issue or opportunity, for example, how to handle a disengaged CEO. After this, the rest of the group will ask you clarifying questions before offering their ideas. To celebrate our milestone of 100,000 Enter the Boardroom downloads, I'm delighted to offer a 10% discount to all our listeners who sign up between now and the end of March. Head to plus.newroll.com and apply the code ENTER, all lowercase, at checkout. What you're describing there, it sounds like an extremely high-functioning, high-performance board environment.
I think it is, actually. And where we and I struggle is actually it's the sheer scale of what we're dealing with and the sheer range of activities that we're dealing with. And so if I think there's a challenge always for any board, and it's a very real one in NHS England, so the budget this year is going to be over 190 billion is the cost we manage. And I gave you that picture of 6,000 primary care practices, and the relationship is an annual contract negotiation, 230 trusts looking after 550 hospitals. You've got 20 royal colleges, essentially, who are the holders of standards for the Royal College of GPs, Royal College of Nursing, etc., etc. So you have this ecosystem you have to manage, and the scale is huge, but the demands on you are huge. So you'll also see the charities, very good, great charities like Macmillan or Cancer Research, or Alzheimer's, all lobbying hard, wholly appropriately, for more resource and more attention into their particular area. And so you have to manage choice. And the real test, I think, for us is that word prioritization. And so what do you choose to do when there is so much to do? And then you look up into Whitehall, and actually the demands on the NHS change all the time. So in my 3 years, there's been 6 different periods of Secretary of State. And each time the Secretary of State changes, the ministerial lineup changes. So the junior ministers in the department change. And they all come in with huge commitment and passion and real intent. But they all might want to do something slightly different than the previous team did. So actually you get changes in the demands that come into the board from our political masters. And that's understood. It's not a negative. It just is actually the way that the system works. The real challenge for the board is, what do you prioritize and what do you focus upon? And what we tend to focus upon is what I call the enabling priorities. So what are the things that if we changed them, have consequential further better changes into the ecosystem? So one very good example was 2 years ago, we produced the first ever long-term workforce plan that the NHS has had in its 75-year history. And that was produced, and it models what we think the workforce changes to look like. How many more technicians do we need, or technologists do we need, or computer? How many people do we need in tech or data science? How many And then how many surgeons do we need? And so in what practices? How many nurses in what practices? How many physios, GPs, and so on? So the first time ever there was a modelled workforce long-term plan produced, which actually gets refreshed every 2 years. And it tries to pick what happens to productivity, how does technology play into the changing, how do robotics work, how do genomics work? Do we need to change our genomic scientists in terms of the number of those? So I'm going to levels of detail. I'm probably being rather boring, but it's a very good example of, if you're the board of NHS England, what's the enabling priority? And the enabling priority is, have you got a workforce plan that you agree with government, you agree with the Department of Health, you agree with the Treasury, the funding for that, you agree with number 10, and that's then a workforce plan that we then in turn engage with universities, training colleges to say, we now need to change the training to produce these different cohorts of medical practitioner as they come through. For the management graduate program that the NHS runs, how many managers do I need to train and what do I train them in so they're really skilled managers in terms of how to manage a hospital as that changes.
You said that chopping and changing with different political parties coming in and ministers coming in is not a bad thing. I was recently involved in a session which was looking at the data on what engages people, and one of the strongest demotivators is someone having a manager who's constantly chopping and changing direction.
No, so I wasn't. You're quite right to pick me up. I don't think I was saying it isn't a bad thing. I'm more saying it's understandable because health is so important, and politicians come in, they're given these very difficult roles and they really want to make a difference. But the challenge for them, and it would be for you and me as well, is, so I want to make a difference. Do I have something I really think ought to change? So when they come in, they change so often. But just the reality of the world is it changes what happens. Now, I would say, I think the way the world ought to work, but it's always messy, is I think that the governments and the politicians and the department, they set the weather, they set the high-level strategy, they deliver the money. So they do money, they set high-level strategy, and they legislate. So much of the NHS, we have 130 objectives in the NHS, would you believe? Of which about 110 are in statute, regulation, or legislation. So governments legislate. They think what they do about what they regulate and what they legislate. But they should leave delivery to then the arm's length body, in this case, which would be NHS England, but other ARBs, and then we do the delivery. Our engagement with the politicians should be, they should respect that delivery. They do respect, but it works best when they respect the delivery, and the decisions about what gets delivered, how it gets delivered, what gets invested in is done by those people who manage that delivery on a day-to-day. And government is setting the high-level strategic intent. They're providing the money, which we then have to manage within, and say they're legislating and regulating. Where it goes wrong is where it does go wrong is where actually that gets mistaken, and you can get politics coming in to think, this is how you deliver, this is what you do. And that, I think, is where that helpful delineation breaks down to the negative outcome. But it's understandable why.
Well, at the same time, I can't help but thinking you're set up to fail. Like, I sort of see parallels. I know the education sector a bit better, where in some ways the sector would rather a bad direction, but it be consistent, than one that's constantly changing in someone's efforts to make a better decision. And I wonder, to what extent do you as a board have the ability to try to change the landscape? Maybe that's just beyond your remit, but to sort of...
No, I don't think so. I mean, I think we can influence it. I think, again, it's that how healthy and attractive. If I took my first Secretary of State and I take my current Secretary of State, I mean, they both have very clear ideas of intervention. So with Sajid, when I arrived at the same time, we might talk about it, there's an announcement about building between 40,000 and 50,000 what are called virtual wards. And that's become quite frustrating. But he was very clear about that because he recognised that one of the big issues is the lack of bed capacity in our acute sector, which have been cut by a third, by the way, in the last 20 years, at the same time as the population has grown 15%. So that's a major challenge. He recognised that. So he had that initiative. So he determined there, he determined on a war on cancer. He determined on the idea for a long-term workforce plan. And then we produced them. So that was very clear. And now the current Secretary of State, Wes Streeting, very clear again on he wants a significant improvement in the in essentially the elective, what we call the elective waiting lists. But he's also embarked on a very important discussion, which is a 10-year health plan, where we do, as the NHS England board, contribute to that as a very significant constituency. But actually what Wes is doing is consulting more broadly, say, well, given those demand pressures, that 3% growth a year turns to 40% more demand, how should we think about what the NHS should look like in 10 years' time? And then that will boil down into a series of priorities. So again, a very clear engagement. That's sort of setting what I call the strategic weather. And so that's where the current secretary, Wes Streeting, is focused, as well as on a couple of priority areas around, in this case, waiting lists.
Interesting listening to you talking there, because again, you sort of get this real sense of a high-performing, innovative organisation, and it feels like there's a real disconnect with the sort of the public narrative of the NHS, which I imagine must be very challenging for the organisation internally to hear that. I'm curious to hear, how do you as a board think about managing that?
They're both true, aren't they? Because actually, I mustn't sound Pollyanna-ish. I mean, I think that the basic provision, we don't meet. We haven't been meeting our constitutional standards in access to fast treatment for cancer. So if you take cancer, last year we did 3 million cancer referrals checks where people came forward and we scanned them for cancer. That's 140% more than 8 years before. It's 27% more than 4 years before. So we're doing 3 million cancer referrals. So we're finding cancer earlier. But one of the consequences is, are we getting people into treatment fast enough? And we're not. So we're failing that. If you look at the waiting lists, they're too long. They're too long. So I think both things are true. I'm not at all in denial of the fact that the basic provision, and I talk about technology and AI, I need to be careful that if I go into many of our hospitals, they've got old kit. They've got, I'll make it up, a dozen passwords, 14 different passwords to activate the system. There's innovation, there's AI, there's ambient documentation, voice to text, all sorts of things we can innovate. At the same time, partly through lack of investment, I think, or lack of sufficient prioritization, some of the very basics aren't working. And we also have to fix those. So the boards, you've got both things are true. The public narrative about basic provision, it's often true, and we're not meeting standards. And at the same time, the NHS is this remarkably innovative, continuously evolving ecosystem.
You touched earlier on the doctors' strikes that you were a chair during those. I imagine those must have been hugely challenging as a negotiation. It's one thing when you're negotiating
strikes. So I should
strikes.
cut across you, because the NHS, we don't negotiate the remuneration. So that's between government and that's between Department of Health, essentially, and Treasury and so on. But, it's government into the relevant representatives of, or in that case, BMA and we deal with the consequences. Now, we can give views to it, but we're not in the negotiations. What we have to deal with is the consequences of the industrial action. How do we make sure to the best of our ability that we continue to look after patients, keeping patients absolutely at the centre? We're about delivery. We're not in the negotiation process.
That's a really interesting dynamic. I'm trying to imagine running a business where I wasn't able to control the salaries of the people engaged in it. Does that make it more difficult as a board?
We were very grateful, and again, to Wes Streeting, the current Secretary of State, and government, and Rachel Reid. Government awarded 22.6 billion of additional funding for the NHS when they came in, and that's 20.6 billion over 2 years. They settled pay awards. So I think over the last year, the pay increase on average across the NHS was about 6.7%, 22% to the junior doctors, but on average about 6.7%. So when you look at that 22.6 billion and you look at pay inflation and you look at medicine price inflation and you look at non-pay inflation, we still have to pay for all our electricity, all the stuff that goes, etc., to run the system. If you look at employers' national insurance, because whilst government is direct employees of government are essentially protected, much of the provision to hospitals are provided by private companies. Laundry, cleaning, portering, etc. can be provided by private companies who are often employing lower paid employees. So they had a higher national insurance cost there. GPs are private businesses, so they see higher employers' national insurance. So when you looked at that 22.6 billion, actually it was more than absorbed in over 2 years just in pay inflation, non-pay inflation, employers' national insurance, and medicine prices. And so actually we still found ourselves having to find, this current year we found 7 billion of cost reduction. Next year, we're looking to find over 9 billion of cost reduction across the system. The task we've given to the system is a total 1% cash cost reduction and a 4% productivity find across the NHS. So there's a real task.
You've demonstrated in this conversation you have a remarkable grasp of the numbers and the system and how it all works. In episode 109, we had Professor Stanislav Szekcznia talking about the role of a chair and how he thinks actually a chair without sector expertise often makes a better chair because they don't cross that line with the executive. Have you ever felt it's been limiting that you haven't got health knowledge?
No, I found it sometimes embarrassing where I can say something that's perhaps just rather stupid, but I'm protected by the fact that I remember when I was approached for the job and I turned it down, it's rather biblical, isn't it? I turned it down 3 times and they kept coming back to me and I kept saying, I've got no health knowledge. In the end, they said, look, that's clearly understood, but we have an abundance of health knowledge. That's not the issue here. The issue is the outsider's view. Hold a mirror up, ask the question. It's about, do you have experience of large organization running boards, prioritization, making choices? Can you do good governance? Can you engage? Can you learn enough about the system to go into the front line and engage with it and understand the pressures that they're under? But I didn't need to be a clinician to be able to do that. And my board has got brilliant medical and clinical experience around it. So I do think an outsider provides. I think there's a question people ask about what does the commercial sector bring that the public sector doesn't. I don't think that's quite the right question because it carries the implication that the public sector doesn't have commercial skill or doesn't have innovation. And it absolutely does. When we talk about bringing in external commercial sector heads, what we're just doing is bringing in an outsider's lens, someone who says, I'm coming in, I'm not coming up through the weeds, up through the wood to look at the forest. I actually am looking at the forest from the outside. So I might just give you a challenging, different perspective on it that might make you think differently about their priorities. And they may have commercial skills or financial skills or technology skills, but we've also got those internally. So it's just the fact they come from outside and they haven't battled through the particular organisation structure that is this public sector service, the NHS. So it's that external lens, I think, that makes the most difference.
So before we go on to the lightning round, I'd love to hear from you. For those execs listening to this who are thinking about taking on a board role within the NHS, how would you advise them to think about positioning themselves? I often talk about board archetypes and the archetypes that boards are looking for. What in your mind are the different archetypes that execs should be looking to position themselves for?
Well, I think the first thing, if we stayed on the trust board, because there are many more hospital trust boards, one, we need non-executives to come forward. We're doing a lot of work on pipeline. We're often having to double hat, particularly chair roles now. Many of our non-execs are coming out of the system, which is really good as they know the system, but I need more external non-execs coming in to give that external lens. I think it's to really try and understand and step back and think a little bit about what the trust is. And actually, you'll very quickly realize it's like a whole town. It's got all the issues you have in an organization, any corporate. It also has very difficult financials to manage because the pressures are huge. And it has very important relationship constituencies to manage, whether it's the local authority or the centre or government or local politicians. So to really step back and just think about that complexity, and maybe you wouldn't take it on. And maybe you simply got to understand that there will be a bias for particular skills depending what the shape of that board currently is. So workforce knowledge, financial discipline, technology and data, really important skill sets. So think about the skills that you bring. But what I would say, though, is, one, we need you. Please come. And secondly, it is a remarkable privilege. And you get to see amazing things and you get to see an amazing engagement. And so I would encourage people to come. And if you have any appetite for public service, which I think is a wonderful thing that we should all have, actually being a non-exec on a hospital trust is a really good thing. It's a really good piece of public service where it might not be enjoyable, but where you'll get huge satisfaction. One of the issues actually there is risk around it. Things can go wrong in the hospital. You can have a real challenge in how you treat. We have lots of problems sometimes in maternity levels and how we treat mental health and so on. So you can have risk and reputation risk and local reputation risk, and it doesn't pay very much. On the board of NHS England, and they are doing a day and a half a week minimum. They get paid £6,700 a year. So you don't do it for the money. But we need people to come forward, and it's a real privilege to do it. But do step back and think about the scale of what you're taking on first. And that might excite you more, actually. It might make you come forward. But they're not straightforward. They're very complex machines that you are joining the board of.
Richard, time has flown, which means it's time for the lightning round, where I'm going to say a short question and ask you for a quick response if you're ready.
Okay.
Best book every board member should read, and why?
I'm currently reading Ronald Hutton's second of his trilogy on Cromwell. When I just read Anthony Johnson on Harold Wilson, and I just read Orbital. So there isn't a teaching book. I think reading broadly to give you context is very important.
Boardroom behaviour that irritates you most?
Not doing the work and then performing and then just being loud.
Most valuable board ritual?
It's the engagement between the board meetings, and it's that dialogue that happens amongst board members, exec, non-exec, amongst the non-execs. It's a very important ritual of communication. I'll often put in a Sunday evening at 6:00. Why don't we just get on a board call and just update? And so it's that ritual of very active communication.
Most significant professional insight?
If I had a sort of a behaviour one, it's a phrase that one of my previous colleagues at Standard Chartered, it was a brilliant colleague, Peter Sands. It was saw and swoop. And so he said, you've got to swoop and do the detail, but then you've got to be able to saw them come up and see the horizon. But you've got to do both. And it's the ability to swoop and then just come up and saw.
Best professional advice you ever received?
I worked for a very able man that passed away called Christopher Castleman. His best advice is make a decision. And the decision can be to do nothing, to wait, but you have to proactively make a decision. And a lot of people don't take opportunities. There's that phrase, you're at a crossroads, which implies that you're going to go one of four ways, that most people don't move and the opportunity comes past. So you have to proactively decide to do things, even if it's to do nothing, but be decisive.
What have you changed your mind on about boards over time?
They aren't in as much control as they think they are. But it's true of life, actually. They manage within the information and evidence that they have. But actually, there's so many things that you don't know that can impact you at any time, the exogenous factors, and they are far greater than what you think you can control.
When was the last time you got a significant judgment call wrong in the boardroom, and what did you learn?
The one I think that was the most difficult for me ever was when we made the decision with all the evidence we had and all the sign-offs and the attestations and the assurances to go on the final migration of the TSB banking systems. And we had planned for 4 times peak volume. We had contingency. It went wrong, and then everyone gets worried. The announcement gets made, and we suddenly have 9 times peak volumes, not 4 times, even though everyone assumed 4 times is the biggest contingency volume anyone had planned for. So we made a misjudgment. It's an earlier point based on the evidence we had, and something was in there that we didn't know about. So it was a misjudgment, and I obviously stand in defense of how it happened, but it's a really interesting reflection. And then the issue is, how do you mend it? How fast can you mend it? How well can you look after, in that case, a banking customer?
Has echoes of Dan Gardner in episode 85, where he talked about fat tail risks and how we constantly underestimate black swan event, not just the probability of it, but also the scale of it. And finally, 3 things our listeners should take away from this episode if they take nothing else.
Values are really important. I think courage is important. Second, actually, for me, is that I think challenges are really interesting, but also really rewarding. They're tough, but you get reward from them. You get a sense of delivery of sort of that you've done something. And the one I'd like to really give actually is that the NHS is absolutely remarkable. It is remarkable. And I know we're struggling, and we're struggling to deal with the demand changes and the growing demand. And we're struggling with a lack of capacity to deal with some of it. Yeah, and errors we make and mistakes we make. And so I get that. But at the same time, the commitment of the staff and the people to looking after the patients and the skill with which they do that, it is remarkable. And I think for the UK, it's one of those pieces of a cultural cement that makes for our society being a much better society, that it doesn't matter who you are, how much money you've got, what you're suffering from, you come through those gates and we'll look after you to the best of our ability.
Richard, that has been an inspirational demonstration of soaring and swooping, in your words. Thank you so much for taking the time to share your experience and wisdom.
Oliver, thank you. I'm not sure it's wisdom, but thank you very much for the opportunity.